Die.
Okay, all right. Good morning, everybody, and welcome to this morning's Board of Directors, this public meeting. My name's Di Bailey, and I'm the Trust Deputy Chair. Okay, are we okay? Are we all ready to go again now, colleagues? Right, so just in terms of routine business then, the only apologies that I've been made aware of are Mark Platts, Kevin and Ian Orrell. We had your apologies in case the tech from France wasn't working, but we've checked it and it is working. So I think you're with us, but staying in the background, obviously, to preserve connectivity for later on. So I think that's it. Yes, good. Still going. Thanks, Ian. Okay, in terms of declarations of interest, we can see from the document that's been circulated where there have been some changes made, but just to give anybody an opportunity that needs to flag anything that isn't in the document that you need to make us aware of. Okay, I think that's fine then. So on to the minutes of the Board of Directors meeting on the 7th of November. These are with us for decision. So I'm assuming that people have read the minutes, and are there any comments or questions? And if not, are people happy to approve, please? Can you just let me know? Yes, I'm seeing lots of yeses in the chat, so I think those are approved. And then in terms of the actions and any follow-up, I just had one comment on the first action, which just for the simple reason that it says in progress and there's an update from October 2024. It's related to the integrated performance report, but obviously we progressed the conversation around this both at the board development session in January and then subsequently at the performance committee in January. So I just thought we perhaps ought to reflect that in terms of the progress update, Karen, if that's okay with you and Amy. I thought I saw something going on in the chat. Just a second. No, I think that's okay. So anything else on schedule of actions? No. Okay, so in terms of chair's remarks, Kevin hasn't flagged anything that he wanted me to say on his behalf. Just one thing that I wanted to say before we get into the sort of more meaty discussions in the agenda. I'm very mindful that we have a lot of papers to get through this morning, some of which are here for information and have already had good scrutiny at committee, some of which are here for decision. And I would like us to spend the time on those items that do need decision. So I'm going to make no apologies if I start to move you on, in line with, of course, the sort of the overarching message that we're getting through the NHS plan, which is all about emphasis on productivity, folks. So let's use the rest of our board time around productivity and see where that gets us. And hopefully we can do justice to the items that we've got in front of us with the appropriate level of scrutiny and conversation. And with that, Sarah, I'm going to hand over to you for the Chief Executive's report.
Thank you very much, Chair. Morning, everybody. I'm Sarah Connery, Chief Executive here at Lincolnshire Partnership. Here is my usual Chief Executive's report. As Di said, I will assume as read, and there is quite a lot of detail in there, including, I did have to make a late entry to the report, the planning guidance for 2025-26, which I've appended there. We have got a session in private board where we're doing a bit of a gap analysis in terms of what the expectation is from us as an organisation and where we are in the planning cycle in order to be able to make those submissions. Just to say that, as our Secretary of State has said in the budget for this year, that the NHS has had investment when compared to other public sector areas. That said, finances are significantly constrained and we must be able to live within our means. I think in terms of my reflection on this as the Chief Executive, everything that's there in the planning guidance aligns with our trust strategy and our vision to support people to live well in their communities. But we won't be able to afford everything that we want to do within the time frame. So we may need to look at how we're phasing our strategy going forward to make sure that it's deliverable, given some of our strategic ambitions do require additional investment. So, you know, we'll keep the conversation going around the planning guidance. I do just also want to say, we've talked in the Quality Committee, and I know it's in the highlight report around the Care Quality Commission review into the care and treatment of valdecoxib. And on the 5th of February, the independent mental health homicide report was released. And what we're doing now is doing a read across to our current action plan to make sure that we're attending to any of the fresh information that we might have through that report. There is a system learning event that is going into the diary as well, because this isn't just about what happens within secondary mental health services. So we'll keep the board appraised of that, and the final report needs to come through in terms of our action plan by June 2025. Obviously that will come through the Quality Committee. And just to end on a positive, want to highlight our refreshed values have now been released into the organisation. We're asking all teams to have a conversation about those values and what it means for them when they're being lived, but also what it looks like when they're not being lived, and team behaviours. And we've asked for that to be completed by the end of March. So lots of conversations going on, and indeed we'll be having the conversation as a board around those values as well. So I'll stop there, Di, in the interest of time, and I'm obviously more than happy to take any comments or questions that people might have on the report. You're on mute, Di.
Sorry, I was just going to say, Sarah, in terms of your comment about the values, I was with two of our mental health support teams on Tuesday who had already looked at the values and were thinking about how they can use them in their work. So that was really good. They were really on the ball. Right, Tim, question from you.
Thanks, Di. Tim Harry, Non-Exec Director. Sarah, many thanks as usual. Really full of stuff. Very quick question on the second no wrong door session, yes, which sounds very productive and lots of things came out. And it's moved on to the series of action learning sets. But I just wondered, because obviously you know I'm a great supporter of it, really enjoy the stuff. But at the end of the day, it's about getting into outcomes, isn't it? I just wondered if you could say how going from action learning sets is going to progress.
Yeah, great question, thank you. So we've now got a lead executive from across the system leading up each of the outcome measures. So we've got that sort of senior oversight to take us into delivery, and we've agreed, we just had our last mental health, dementia learning disability and autism exec meeting this week, where we've agreed that we will start to measure those outcomes from the 1st of April. It's not going to be perfect to start with, but the challenge that we've set ourselves is there's lots of work going on. Is it actually making a difference to people's lives through the lens of those outcomes? And something that I've asked the support hub to do, a bit like we have for the East Midlands Mental Health Alliance, is a bit of a common board paper that comes out of that group, so that all of the key organisations can take something consistent to talk about the progress that's being made and any risks to delivery. So I'm hoping that we'll have that. Well, we've set the target of having that from April going forward as well.
Thanks,
so
Sarah.
Hopefully that's helpful. Thank you.
Thanks, Tim. I'm not seeing any more questions or comments, Sarah, so thank you as always for a very comprehensive and informative report. Thank you.
Thank you.
Okay, so Karen, I think the next item is with you, the Board Assurance Framework.
Thank you, Di. Good morning, everybody. I'm Karen Scott, Trust Secretary. So this is the board's Q3 review of the board assurance framework. I'm not going to go over the report in any detail given Di's comments, but just to specifically draw out the fact that each of the respective board assurance committees has reviewed its section of the board assurance framework as is usual, and any recommended changes for approval by the board are highlighted in the document appended. That has then subsequently been reviewed in its entirety by the Audit and Risk Committee and is recommended for approval. In the report, I think that colleagues will have drawn out that there was a common theme in discussion at each of the board committees that the risk score, the target scores for the end of the year, there's some debate and discussion about need for review regarding those. Anticipated that there would have been potentially some more apparent progress during the year in terms of achieving those risk scores. That hasn't transpired so far. So I think we need to carry out some more comprehensive review about whether or not it's appropriate, the target scores are appropriate, or whether we need to consider that those need to be more in line with the trust life cycle of the trust strategy, or whether or not we're being quite as fair or as precise as we might be about identifying progress that's been made in the strategic delivery plans. So I think that's maybe up for discussion by the board, but I'm suggesting that during Q4 that we start to review that, and I'll work with executive directors responsible for each of those sections, and we'll have another opportunity at committee before the end of the financial year. Other than that, Di, I'm more than happy to open up for comment or question. Thank you.
Thanks, Karen. And I think your point there about making sure that this is the dynamic document that we continue to review in the light of the strategy and the life cycle of the strategy is really important. So I think that makes absolute sense. I'm not seeing any questions or comments. So I think the work that's gone into this, as you rightly say, has been felt right across the committees, and importantly so. So I think we're good to agree that that this is our current board assurance framework. Thank you.
Thank you, Di.
Okay, so if we stay with you then for the organisational risk register, and can I just ask Karen, because I was just on the point that you made about the board assurance framework, we've got some risks in here, haven't we, where we've got quite high or extreme scores, and then a very short time frame that our target risk score is hopefully going to be a lot lower. So this almost seems to fit the conversation that we've previously had about the BAF.
Yes, Di, thank you. So just moving on to the organisational risk register, I think that the two are working in parallel, and there's some very cross-cutting work between the two documents that has been going on recently and needs to happen moving forward. And I neglected to point out under the BAF that actually, dependent on the board's decision regarding proposals today regarding the risk register, that could impact or will impact on the board assurance framework in terms of those items, those risks that may not feature because they've been removed from the risk register. But absolutely. So I think really, as much as anything, to summarise, I really wanted to talk about and pull out some of the work that's taken place since the last board meeting in regards to the risk register. The board placed an action on me to go away and actually have a discussion with Audit and Risk Committee members about the formatting, the appropriateness of some of the risks, etc., the descriptors, the scores, etc. So some quite extensive work took place working with the executive team and then subsequently with the Audit and Risk Committee members to actually look at that in more detail. In parallel, there was a comprehensive review of the Trust's reporting and management of risk policy, and in that there was significantly quite a change in the Trust's proposed approach to how it manages risk moving forward, and particularly in relation to whether or not it features on the organisational risk register or within a divisional risk register. That policy was subsequently approved by the Audit and Risk Committee. And so within this report today to the board, and all of that has actually been summarised, hopefully quite clearly, there are a number of proposals that actually made to the board in terms of which risks it's suggesting should be transferred from the organisational risk register to divisional, some that are recommended for closure, which requires the board's approval, and then a summary of what, subject to approval, what that would leave us with in terms of the risk register. I think it's reasonable to say that Audit and Risk Committee were comfortable and more comfortable with the register when it reviewed it in January. And I hope that the board has seen some significant change in the way that it's presented today. I do believe that this will be very much more iterative, and I've made reference previously to the Trust's procurement of a new information system, which will actually facilitate a much more intelligent and dynamic analytical way of reporting risk moving forward. So I'm looking forward to that. So I'll leave it at that, otherwise I'm in danger of going on too much, Di. But I think in the assessment, it clearly points out the things that the board is asked to approve. Yes. Thank you.
Thanks, Karen. And I think, yes, it certainly does that in terms of, and also I think in terms of what you're proposing in terms of moving some of the risks to the divisionals, and leaving us with a clearer organisational risk register is really helpful. Ian's been closely involved with this, obviously at Audit Committee. Ian, you wanted to come in and make a comment.
Yeah, thanks, Chair. To be honest, these are the comments that I was going to be making later, but it just feels more appropriate to follow what Karen said. I won't repeat what Karen said, but excuse me. It's clearly the case that a lot of work has been done in this area, and there are a lot of improvements that can be seen already. No system is going to be perfect, and we know there are further things to be done in terms of bedding down. But I just wanted to reiterate really what Karen had said, and the Audit Committee gave this a pretty good shake, I think it's fair to say.
Thank you, Ian. That's helpful to know. Okay, can I just ask then if colleagues would indicate their agreement to move forward with the recommendations in the paper as outlined, please? Yes, there you go, Karen. It's good to go. And again, thank you for all your hard work with this. It really is in a much improved place. Thank you. Right, so we move into the part of the agenda now that is dealing with outstanding quality. So Sarah, this is your opportunity to just draw to our attention anything that we need to be drawn to. Sarah Whiteman from the Quality Committee.
Good morning, thank you, Chair. Yes, so Quality Committee last met on the 9th of January. In terms of the highlights, we remain focused on the learning from the tragic events in Nottingham, the Valdo Calocane case, where a patient with treatment-resistant psychosis inflicted some drastic injuries on some members of the public. So these were issues around risk assessment, medication, not listening to family concerns. We're key in leading a system learning event for that, which is to be confirmed. As part of the Quality Committee, we've also made a decision to include patient stories as part of the board, and this is to link with the board stories in a coherent way, but so that we remain embedded in what we're all here for, which is about doing the best for our patients and making sure that the care that and services we deliver are value for money, but also evidence-based, and obviously improve outcomes for patients. We noted that the establishment of the confirm and challenge panel, so that posts are being carefully considered in terms of the quality impact assessment in the context of the current financial constraints. I also just wanted to bring to your attention the excellent work of the Chief Medical Officer in an innovative approach to mental health factor assessment provision, and the Chief Nursing Officer's team in reducing restrictive practices. Next meeting, we're going to be focusing on the learning from PSERF, which is the patient safety reporting framework, and how that's being embedded in the organisation. Thank you, Chair.
Thank you, Sarah. Any comments or questions for Sarah? No? Okay. Thank you. So we stay with quality. Sharon, and over to you for the annual report on board stories.
Thank you, Chair. Sharon Harvey, Chief Nursing Officer. So as Sarah's just outlined, the Quality Committee received the paper that the board are now receiving, and we've updated it following Quality Committee. So the purpose of the paper is to share an update following the year's board stories that the board have received. The decision that's being asked for in the paper is in relation to the approach for the stories for the year ahead. So the report's been written to reflect on the board stories that have been presented between November 23 and November 24. And as we heard this morning, each board commences with a story, either from a patient, carer or staff member, so that we're really clear and set the scene for every board to make sure that we consider the trust vision and values in everything that we do. The paper outlines the stories and updates against each, so I won't go into detail to those. What's really positive is that the board has continued to hear from patients, service users, carers, and from our staff in the last 12 months. But I do feel that we could make some improvements in the structure and the approach to how we hear from people and their families at every point. So the Quality Committee considered a recommendation to hear a patient or carer story at the start of every Quality Committee, similar to the approach that the People Committee take in hearing from a staff member, and the Quality Committee supported that recommendation. We also discussed as a Quality Committee the opportunity to align the future board stories to the trust strategy. So previously we've tried to align the stories to our quality priorities, and we would continue to do that through Quality Committee. But when I talk about aligning to the trust strategy, I mean in terms of the patient experience and carer experience of the elements of the strategy, not trying to detract from that in any way. So happy to take any comments or questions. I'll stop there, but the recommendation and the consideration for decision is whether the board would be supportive of the what I see to be an improved approach to choosing our board stories. And the only additional comment, I guess, is we know there's been some seldom heard voices, some voices we've struggled to hear at board, and Quality Committee and the executives really received that challenge and welcomed that challenge, and we'll be looking at how we can do that. And I mean, for example, somebody experiencing dementia, or we haven't had a story from somebody with a learning disability. I'm really open to doing that, and the board will have to be prepared for the reasonable adjustments we might need to make in order to do that meaningfully. Thank you, Chair.
Thanks, Sharon. And I think this morning's story actually was a really good example of where it was a voice that we've heard, that we hadn't heard from that service before. And I think Hannah really eloquently explained that in an earlier period she probably wouldn't have been able to come and tell us that story. So I think that really is important. I think the only comment that I would make as chair of this meeting today is that sometimes I know how difficult it can be to get people to step into this space for all sorts of reasons. Yes, we must make those reasonable adjustments, absolutely. I think my priority would be that even if it doesn't quite align with the strategy, I'd rather hear the story than not, if you know what I mean. But yes, I think the point is well made.
If it's okay to just come back in quickly, Di.
Yeah.
I should have said as well, we did have a discussion at Quality Committee about the support we could gain from the Council of Lived and Learned Experience
Yeah.
to understand what else we can do to make it easier and
Absolutely.
more comfortable for people
Yes.
to present at board, because it's really scary for people and it's really hard and it's in the public domain. But I know we have allowed for private board for people that don't want to tell their story in the
Yes.
public domain as well. Thank you, Di.
Yeah, thank you, Sharon. Okay. I'm not seeing any other questions or comments other than Chris. Actually, Chris Wright and Sarah both saying that this is a really good report, and I would echo that. So I think in the absence of any dissenting voices, I think we're okay with the recommendations, unless anybody tells me otherwise. Can you indicate in the chat, please, that you are? Yes. Yes. Thank you. And we're staying with you, Sharon, for the Information Prevention and Control Board Assurance Framework. This is for information, isn't it?
It's for information. So this paper is presented to board fairly regularly, often quarterly, to demonstrate compliance and improvement against the Infection Prevention and Control Board Assurance Framework. It's my responsibility to ensure we do share this at board, and so what you've got in front of you is the Q2 update. You'll see there's been some improvement in compliance since the previous report came through, and that's largely because we've been waiting on an audit tool, which we've now received and have been able to progress. The detail in the paper hopefully outlines where we've still got some areas of compliance to improve on, mainly around fit testing. And I'm happy to take any more questions and comments. If they're very detailed questions, I might need to pick them up outside, but happy to take any comments. Thank you, Jo.
Thanks, Sharon. No, I'm not seeing anything, so I think we thank you for the update. And we're staying with you for the Safer Staffing Establishment Review.
Yeah, sorry, just trying to get to the right paper. So the Safer Staffing Establishment Review. So it's a requirement of me as the Chief Nursing Officer to demonstrate to the board that the Safe Staffing Establishment Review has been conducted twice a year in line with the Developing Workforce Safeguards recommended by the National Quality Board. So this is one of those reports of the two in the year that we do. Colleagues might be aware of an article in the media around safe staffing on our acute wards, and I'm hoping that this paper will further demonstrate the assurance in place and the rigour in place in order to ensure we have safely staffed our wards in line with establishment. So the papers for decision, and the decision is for the board to be assured against, is that we've followed due process in relation to the Safe Staffing Establishment Review, and there are a number of recommendations in here as well. So the key points I want to draw attention to is, firstly, we've put some additional scrutiny and rigour into our Safe Staffing Establishment Review process this time. So previously, I would have presented directly to board. This time we've taken this paper through Quality Committee to ensure there's robust challenge from a quality perspective in order for me to make the recommendations to board. Underneath the Quality Committee, we've additionally put in place a confirm and challenge panel to really look at the detail, the evidence and the data behind our behind the recommendations coming in from the clinical teams and the safe staffing function within the organisation. We've looked at how we can align more closely to the planning process, and so our planning lead and finance team sit on the panel for awareness and ensuring it aligns to process, not to make decisions. So the finance team aren't there to support or decline, but they're there for awareness in order to ensure they can fit with the process. You'll see within the paper that the panel provides some additional scrutiny on the recommendations, including the challenge for reassessment in relation to the wards, one of our rehabilitation wards. So there was a request for increased staffing on the wards, And following confirm and challenge and initial discussion, we did not support that recommendation. What I want to assure the board of is that that is because we were assured that the establishment enabled safe staffing. It's not that the ward wouldn't benefit from additional staff. All of our wards would benefit from additional staff, but this is not the process for that. This is the assurance process to ensure our wards are safely staffed. What the board are being asked to support the recommendation of is increased staffing on Ellis Ward, and that is in relation to, since the ward has moved to the new build and away from dormitory accommodation, in order to safely manage observations, we need to increase the establishment by 2.5 support worker staff. For additional assurance, so that the board don't feel that we've been not safely staffing in the interim, we've been using temporary staffing. So the staff are still at the establishment we're recommending in terms of how many staff they're trying to get onto each shift, but they've been using temporary staff rather than being in the baseline establishment. I'm sorry, that's not as succinct as usual, but I wanted to give the details.
No.
So as the paper states, we're asking for the recommendation in terms of the increase for Ellis Ward and to support the due process has been followed. Thank you, Chair. Happy to pick up any questions.
Thank you, Sharon. I think that was really clear, and I think it's really important to be clear that this is about assurance for the process of going through the safer staffing review, and obviously that recommendation has come out of that. Okay, I've got a couple of comments and then I will come back because I had a couple of comments as well. So Amy, I think your comment relates to the paper. So
yeah, hi, Amy Beaton, Chief People Officer. I think this is a really great report, Sharon. What I really think is a way forward is it's acknowledged the limitations of the tool that we use, and what I was really encouraged to see is that we then use patient and staff care process related measures triangulated with what the tool shows us and professional judgment. And I think the paper is an example of how we've done that with the recommendation for the ward in question. So really commend that approach. And also thanks to you in terms of that confirm and challenge additional layer process that's been implemented. I'm really pleased to see that workforce teams are involved in that panel and that additional confirm and challenge. And I'm particularly pleased to see the utilisation of the dashboard, so that more regular reporting in between these establishment reviews, and to support that, I think that's a welcome addition. And finally, I do feel that this establishment review is often sat outside our planning round. So it was great to see in the paper that that's now going to be brought into the planning round, so that it looks at our capacity, productivity, workforce and finance in light of this review. So it was just a comment from me, Di. I think this is a real progress and way forward, and thanks to Sharon for the work on it.
Thank you, Amy. And I think
and to your team.
Yeah, thanks. And I think I would echo some of that about pulling together of the information. Chris, right, I'm going to invite you to pose your question now, if you so wish to do.
Thanks, Di. It wasn't really a question. It was just trying to get some clarification on the MOST tool and its limitations, and I think Amy and Eve in the chat has just helped me understand that. So, however, having the opportunity to I do think we do need to challenge ourselves really hard on issues of how we use existing resource, and if we're serious about productivity, then we are going to have to make some tough choices. And of course, staff safety is absolutely, or safe environments are absolutely fundamental. But I'm just wanting to understand that we are thoroughly testing every opportunity we can, where we're getting full productivity from the existing establishment. And that I just need to receive or hear evidence of that, I guess.
Okay, thanks,
Are you
Chris.
happy I come back in on that, Chair? Is that okay?
Yeah. Yep.
Yeah. So in terms of one level of assurance I'd like to provide is my understanding is this is the first time we've had a request for additional staffing through the Safe Staffing Establishment Review process, and we've declined it. So in terms of additional rigour, I want to be really clear that we've put additional rigour in, and we've made a difficult decision not to progress something that's come through the establishment review process. However, I also want to couple that with that is because I am assured, looking at the data, looking at the intelligence, and looking at the information, that the ward is safely staffed. In relation to the request that we're looking to seek for Ellis Ward, because the building is so much bigger than the previous ward, because patients aren't in dormitories and they're in individual bedrooms, it takes physically longer for the staff to walk around and check everyone is okay. And we've tested that out, and I was really impressed with the clinical team who didn't put this through initially as a request for additional staffing because they wanted to test if there was a more productive way. They wanted to see if there was a different way to use the resource differently, and they found that there wasn't. They found that the only way they could physically and practically check that everybody is okay and keep everyone safe was by using Bangor agency up to the level that I'm requesting for the increased staffing. Really happy to have a further conversation around that, or to show people the difference in the two environments so you can see just how long that takes. And equally, if there's anything else that we think would benefit putting into the rigour of the process so the board can feel assured when it comes through, I'm really happy to receive that feedback. I'll have conversations.
Okay. Thanks, Sharon. I think what that really highlights actually is that obviously we made a decision as a trust to invest in the new accommodation to improve patient care at Peter Hodgkinson Centre. I think what we're what we need to be mindful of going forward is that sometimes there are some unintended consequences of that, which we need to give some further thought to, and they may not be immediately apparent. But I think we've got some good learning now that we can factor, particularly into developments like the Norton Lee site, so that we consider the staffing complement alongside the alongside the environmental. Yeah, go on.
Could I just provide one bit of additional assurance to board in relation to that, because I'm minded that we've got two of our acute wards that are in the new build. So I want to make sure that board are aware for Castle Ward, our other acute ward, they'd already had an increase in the establishment and uplift to account for the new ward. That is outlined in the paper, but I just wanted to be really clear there won't be an additional request coming for that. And for the Boston ward, we've factored that in just to provide some assurance.
That's fantastic. Thank you. Thank you. Okay. Girish, you have a comment.
Yeah, thank you, Chair. I'm Dr. Girish Kunigiri, the Chief Medical Officer. Thank you, Sharon. While I was reading the paper a couple of days ago, and we have had these discussions before as well, I'm just challenging myself that when we are doing this, safe staffing, of course, this is the minimum requirement, what we want to keep our patients safe. But I'm also just stretching myself whether we need to come together and then see how we can see what should be the establishment on the wards. And similarly, there is a proposal, what it needs to be in the community as well. So we need to look at the other professionals, which also need to be present in terms of the right numbers, so that as a ward environment or as a community environment, we are not only able to provide just safe, but also what is meaningful to the patients and families, and how we all as an exec team work together in terms of making that happen. Thank you.
Thank you. I absolutely agree on that. And just to be clear as well, our head of nursing is involved in the development of the community safe staffing tool and in the update of the MHOST tool. And I recognise there's been a message in the chat in relation to how we realise the savings in the financial position. to be really clear, this is a cost pressure to the organisation, but we can't safely staff our wards without it. And so it's my responsibility as the chief nurse to ensure we safely staff our wards. Thank you.
Thank you, Sharon. I think that's really clear. Just a couple of comments from me. I thought Appendix 1 in the document and the tables in the document were really helpful in terms of helping board to see the difference between the the MHOST recommendation and where we land when we factor in that additional intelligence around staff and patient experience. And I thought that this could be built on in terms of, so the tables, for example, where we have the vacancy position, I thought was really helpful. I also think it could be built on in terms of including information about freedom to speak up cases and any complaints or representations that we've had in those areas. So I wasn't sure whether that's being factored into the the inpatient and acute services review that's that we've been involved in. But I think from a board perspective, it would be useful to have some of that information captured for us that we can look at. I know this has to be reported, in line with statutory reporting, but I don't think we should be hampered by statutory reporting if we've got something that's useful to us in terms of understanding where we're going. So I suppose it's an invitation really to you and to Quality Committee to have a look at that and see what would be useful to come back to us, because I also think it feeds into the conversations we've been having at Performance Committee about the balanced scorecard.
Absolutely. I'll take that and reflect on it and work out to do it, if that's okay, Di, rather than respond now. Is that okay?
Yes, I'm very happy to have a further conversation afterwards if that would be helpful. But I thought there were, that content was really useful. Okay, thank you. And I think that was important that we took the time with that paper. So, colleagues, I'm asking you for a decision here about whether we approve the recommendations in the document. I think Sharon's been very clear about what the requirements are. Yeah, thank you. Thank you for that, Sharon. We have agreement to go ahead with the recommendations as outlined for the 2.5 whole time equivalent at Ellis. Okay, so I think then we're staying with quality in terms of the learning from deaths report, Girish, which is with you. But I just wanted to double check before we go into the report in detail. My understanding is that this report has not been to Quality Committee, so it's come direct to board. And just a couple of comments from me before you introduce it, really. I think we've seen this report in this format at Quality Committee and at board on a number of occasions now before we had the introduction of the Patient Safety Incidents Response Framework, or the PSIRF as we know and love it. And I just felt that maybe in future we needed to frame the learning from death within that context a bit more, particularly around the kind of wider learning. So given that this one hasn't been to Quality Committee, I think this is what I would like Quality Committee to do is have a look at this in the light of the PSIRF and think about what needs to come back to board as a more perhaps strategic document in future. But happy, Girish, it's here for information if you want to say anything about it at this point other than what I've just outlined.
Yeah, thank you. I think that is really helpful. I was having some discussions with Sarah as well, and from next time, when I come to the board, because it's a requirement that this paper has a cite from the board, from next time onwards, I'll just bring a one-page highlight summary rather than the details, because it is anyway discussed in the Quality Committee before coming here. So, and also this is with regard to the timings as well, in terms of when the papers come to the Quality Committee and when they come here with regard to the timelines. So this is basically to assure the board that we as an organization have a robust process in terms of screening and learning from unnatural or suspected deaths. I think what you can see in the paper is in all the divisions, the trends over the last 12 months have indicated that the variations are within the expected range. And there has been a lot of positives in terms of the findings, following some of these mortality case reviews and so on, wherein we have emphasized on team working, patient and family involvement, and also accessing risk. However, in cases where there were lessons to learn, the themes were somewhere on the similar lines, including communication as well. So we need to make sure that the learning is consistent, and we have different ways of having the robust learning process across all the divisions and all the teams. However, what is practically very challenging is, in terms of actually knowing and measuring the impact of the learning and the action plans we put in place. There is also a separate attachment with regard to leaders, which is learning from deaths with people with learning disability and autism. Again, next time onwards, I'll make sure that there is a very brief paragraph related to that in my main paper, rather than putting it as an attachment. Just for your information, that all deaths related to people with learning disability and autism is reviewed at the ICB level, and most of the times it is because of the physical health reasons, and whatever we have done at the ICB level is in line with the national data. Last time the board helpfully made some inquiries into a number of issues which I've highlighted, but I need to just note two of them in that. So one was with regard to the comments related to analyzing based on the population health management. Although we are exploring this, I need to just mention that because the number of deaths are small, we need to be careful in terms of making interpretations with this. And the second is, again, as I was alluding earlier, in terms of the assurance of impact on learning and the actions. This is an ongoing process, and I'm pleased that our Deputy Director of Nursing and Professionals is establishing a continuous quality improvement and triangulation of learning forum, which will be an additional measure to assure that we are able to demonstrate through our triangulation that we continue to be a learning organization. So in conclusion, this report is for information and to be assured that we have the right processes and measures in terms of learning from deaths. Thank you, and happy to take any questions.
Thanks, Girish. No, I'm not seeing any, so thank you. So I think we can move on then to the Patient and Carer Race Equality Framework, or the PCREF as it's known. I think this one's with you as well.
Yeah, thank you so much.
And this is for decision, isn't it?
Yes, this is for decision. And again, apologies, this is a very long paper, and next time I'll make sure that I put a one-page summary so that it is easy for the board members. And this paper is to seek approval from the board to publish our data on PCREF by the end of March 2025. So PCREF, which is Patient and Carers Race Equality Framework, is a relatively new framework which is launched by NHS England, which was in October 2023. This is to tackle health inequality among patients and families in mental health, dementia, learning disability, and autism, mainly based on race, both and also among our staff. For the purpose of what is more meaningful to our patients and our geography, we are very mindful that we also have some specific, population segments, particularly with the seasonal and Eastern European workers, and hence we have amended, our paper to include the people from this part of the world, and also travelers and gypsies, which is very relevant to our population. So just a brief background with regard to the PCREF, there are 3 key strands which are divided into 6 core organizational principles. The 3 key strands are leadership and governance, which is related with our statutory requirements. The second one is our cultural competencies, which is basically the organization and the staff working are aware of the cultural needs of our population and deliver the service based on the cultural needs. And the third is in terms of patients' involvement across all the organization. And compliance to this framework is based on the self-assessment template, which was produced by NHS England, which is enclosed in appendix. It is expected that during the CQC visits to all the organizations, this will be one other measure to ensure whether the organizations are compliant with this framework. I'm pleased that LPFT is a part of the national pilot in the implementation of this framework, and we have fully integrated with the system level health inequality group, as we can understand that anything related to health inequality and race needs to be tackled at the population level rather than just at organization level. Again, one point of caution is interpretation of the data. Because of the relatively small size of ethnic minority population in Lincolnshire, which is 4% compared to that of the national figure, which is about 19%. So some of the key findings which are attached in Appendix 2 are, we have found that the BAME population are more likely to be detained than the British whites, which is again national statistics as well. However, we are relatively less, which is good. The number of restrictions which are placed on the BAME population is also relatively less, which is again positive. But what has not been so positive is access to services, which are relatively lower for people with ethnic minority, particularly in the CYP service. And it is also challenging to measure the competency of the staff in delivering the service that is personalized, which is based on cultural sensitivity of the individual. However, there are specific attempts which are being put in place, although this needs to be consistently followed. We have some targeted support, such as in perinatal mental health services for people with BAME background, and also for travelers, and there are wide measures of engagement with our VCSE group. The other challenge we have is also in terms of obtaining the right data and doing the right analysis based on ethnicity and other wider protective and socio-demographic determinants. And this is currently being looked at, some of which is in the second appendix, which is attached. There is more work which is also to be done with regard to patients' involvements at all levels within the organization, and also involving them in service development and service redesigning, and how we capture that as an organization. Well, I'm pleased that with regard to the staff, particularly from the BAME population, our organization generally has a very supportive measures, including the specific staff network for BAME community, which is called as the REACH. I'm also pleased that we now have a dedicated resource who is called as the Health Inequality Fellow, which is partly funded by the Royal College of Psychiatrists, and this has helped in terms of progressing this work. And I'm pleased that this post is likely to continue in the next financial year. So the next phase for us will be specifically focusing on meaningful collection and interpretation of the data, and how we specifically involve the patients at all levels of the organization, and also in terms of building consistently the cultural competencies among the staff who are delivering the service. So I'll stop here, and I'm happy to take the question, and I'm hoping that the board will support in terms of publishing the data, but I'm also conscious that there are some elements which needs to be completed by the end of next month, to be on the website. Thank you.
Okay. Thanks, Girish. I think what was really clear there was obviously we've come a long way. There's still work to do, and our aspirations of what we want to do are really clear. So I think that was helpful. So really, what the decision that we've got to make is about publishing the information on the website as required. So this is a requirement, and I'm assuming that this is because it's a requirement for us, it's a requirement for all other mental health trusts. So once this is out there, we can also have a look at what other people are putting on their website and hopefully learn from best practice as well.
Yeah, that's very true. And because we are part of the pilot site, we already have some intelligence in terms of what others are putting, and we have shared some of our templates confidentially. Thank you.
Good. Okay. So can people just indicate their agreement then that they're happy for us to put the data on the website, please? Yes, that's fine, Girish. So we can do that. So go ahead. All right, I'm going to take a break at this point, folks, because we've been going for nearly an hour and a half. So I'm going to give you 12 minutes. So can we be back at 22, please? Give you time to grab a drink and have a comfort break. Thank you.
Thank you, Chair.
Okay, are we ready to go again, folks? So we're moving now into the outstanding people section of the agenda. So Tim, over to you for the report from the People Committee, please.
Thanks, Chair. So we've got a number of items which we discussed at the last People Committee, which are elsewhere on the agenda. So I just wanted to draw out 3 other key points that we discussed. The first one was a deep dive on managing attendance. This was a cross referral from the Performance Committee as a result of there being some areas of high sickness, usually associated with high vacancy rates, that was causing some service challenges and performance. So we gained assurance around, well, a certain level of assurance around the management of sickness, but we were also told of a number of actions that were already in place to improve this. But it's also important to think about the reasons for the absence in the first place, and that's part of the scope of work that's being carried out. So we will receive a further deep dive update in April at our next meeting. The second thing I wanted to raise is around health and safety. So this is a relatively new addition to the scope of the committee. And while health and safety estates compliance is covered by best use of resources, the People Committee covers the breadth of health and safety in the Trust. The committee were very pleased to hear of much positive progress. This was supported by an internal audit that concluded reasonable assurance. And I think one of the things that has happened is that a number of key hirings have been made, and those individuals are really making a difference. I think it's important for the board that we ensure there is a sufficient profile of reporting around health and safety to the board. So I propose that will obviously continue through this health and highlight and exception report. The third point is a little bit of a nebulous one, but I just really want to give a heads up. One of the themes that came out across a number of the agenda items were things around leadership and culture. So really just giving, as I say, a heads up to the board at this stage. I think we need to probably reflect a little bit more and evaluate before we come back with something more specific around this sort of area. Anyway, Di, those are the key things I wanted to get over.
Thanks for that, Tim. And with regards to your latter point, again, I already mentioned, doing a visit earlier in the week where I met 2 of the mental health support teams who had done the work already on values. And I think what was really key there was the leadership that the team leader and the service manager had showed, which was really playing through in terms of team cohesiveness and peer support. So I think that cultural piece is really important. And I think we need as a board to have a further conversation about how we draw some of that together, maybe in a board development session or in a private board session. So Karen, maybe if that's an action, I think, for us to pick up and think about how we might take that one forward, please, if you can. Okay. Yes.
Can I just come back on that? Because yeah, that would be fantastic. And I think that's right. And you've highlighted there were some really good examples of leadership and culture in the organisation. One of the things that comes out, and that includes from Stu's report on freedom to speak up, is an inconsistent application of leadership. And that's something we need to consider.
Absolutely. Yeah. And there are so many strands to that work, aren't there, that pick up, the inspirational leadership programme, where that's going, and other things. Amy, I think you quite rightly probably want to comment.
Thank you, Di. Yes, I just wanted to assure the board, really. We started this conversation in our senior leadership team earlier this month around the variation in leadership and our space as a senior leadership team in that and what we could do. So we had our head of organisational development kick off that conversation, and we did identify a number of things that we felt would be helpful. And so we, happy, Di, as you suggest, for that to come into a board development session. But I just wanted to assure we have taken the action from People Committee, and we're progressing with it.
Okay, thank you for that, Amy. Really helpful. Okay, any comments or questions for Tim? I can't see any, Amy. So do you want to carry on then? Because the next two items are with you. So it's the Equality, Diversity and Inclusion Annual Report, and that's here with us for a decision, I understand, in terms of, and you wanted a bit of feedback about the format.
Yes, thank you, Di. So yes, as you say, it is responding, this report responds to our statutory duty to promote equality amongst groups of people who have specific protected characteristics as defined by the Equality Act and our public sector equality duties, and also our contractual obligations in the NHS contract. So I am looking for board's approval to publish this report today. What I would like to say, Di, I will walk the board through. However, this has been through people governance. So it's been through 2 people governance forums, including the people committee, where it's had some scrutiny and confirm and challenge. So the report brings together all of our equality, diversity and inclusion reporting. So the board will have seen previously our workforce, race and disability equality schemes, our gender pay gap, and on today also is our EDS, so equality delivery system scheme. So it brings all of that under one report. It looks at it through the lens of all 9 protected characteristics. So some of our other reporting is more narrow of a lens around certain protected characteristics. This encompasses all 9 for our workforce. And you will also see a section around patients, although we do note that we've got more improvements to make in this area. And as our Chief Medical Officer has just stated, we have got a patient inequalities post now in the organisation that will help us further and make improvements in that area, which will be included in this report going forward. A note of caution to board is this data is around April 23 to March 24. So hence the reference to our different trust values and a different strategy. And although we are within the mandated timeframes for publication of this report, we obviously have since had data and intelligence that will make this very soon out of date. And then hence that's why I've made the recommendations in the paper I have for future presentation coming into board. Although what I would like to say is hopefully the board will see that some of the analysis has shown the key areas of focus are already known to us through the other data sets that we've seen or the other intelligence. This is addressing systemic issues. So we would likely see our focus areas remaining the same for some time. We're not likely to see big shifts really quickly. And so, you know, we will need to prioritise some of the same things consistently to address these systemic and cultural issues. So in the paper, you will see our approach has been to focus on a fewer number of priorities that we see to some degree show inequalities across all or most of the protected characteristics. The paper's identified those, and as I said, not surprisingly, they focus around our staff harm agenda. So bullying and harassment and discrimination between staff to staff, or managers to staff, and then violence and aggression and discrimination from patients to staff. And then the other area of focus we've recommended is recruitment, which indicates everything from attraction to onboarding. And these have also been identified because the focusing on these areas, and they are big areas, but they'll have positive knock-on effects into other areas of inequalities as well. So by focusing on recruitment and de-biasing recruitment, we should then also see our representation of BAME colleagues in senior roles increase. So that's why we've driven our resource into these areas to have that great greatest impact, and also rather than, as we've done previously, in having a very big full action plan which we've had to spread our resource on, and therefore we don't see any noticeable shifts in the dial really on some of those metrics. And to conclude, what I would say is the annual equality report asks us to report under 3 generalised headings as detailed in the paper. And there's not a lot of guidance around what to include in answering those headings really in each. So in some way that's good. It gives us the freedom for us to include what's important to us under those headings. But what we've also done is we're looking at other organisations to look at what's best practice and then make that relevant for us. Okay. We are required to submit for a deadline, but I think we've got poetic license on submitting earlier than that, which is why I've made the recommendations I have in the paper around bringing all equality, diversity and inclusion reporting into board at the same time. So it's easier for us to understand and see themes rather than drip feeding it across the year. And then we can spend our time focusing on the delivery and the discussion around progress and outcomes rather than always analysis around the information. So I would just like to draw the board's attention to the recommendation section, so when they're commenting and questioning, they take into account those recommendations. And my final point, just from obviously our Chief Medical Officer delivering PCREF, is I'll also cross-reference the workforce elements in PCREF and include them in that one reporting so that we've got better alignment.
Okay, thanks, Amy. I think your recommendation that we make this work for us in the way that we want to report is really important. I think your point about this being a retrospective report, from what I'm hearing, we've already, in a way, I want us to spend less time on this really and get it in and get on with doing the delivery, because actually we're streets ahead in some ways in terms of moving forward with the actions. So, okay. I think that makes real sense. Any comments or questions from colleagues or? No, I'm not seeing any. So could colleagues just indicate that they are happy to approve the recommendations as, okay, great. Thanks for that, Amy. So we stay with you then for the equality delivery system, all domains.
So thank you, Di. I'm going to pick up domain 2 and 3 and then hand over to our Chief Medical Officer for domain 1. So obviously, again, asking approval from the board today. Board are ultimately responsible for our quality delivery system. It's written into our NHS contract, so I have to gain approval of board for submission to NHS England and publication on our website. And just to assure board, again, this has been through people governance and had that scrutiny and confirm and challenge. So from a domain 2 and 3 perspective, what the EDS does really is recognise that staff are also our patients and also part of the community groups in which we serve. So we're now being encouraged to monitor the health and well-being of our workforce, to focus in on prevention. But also because our staff form part of those community groups addressing inequalities amongst our staff as well. So that really is the purpose of it. EDS does look at it all through 9 protected characteristics again. It's split across 2 domains. Domain 2 looking at the health and well-being of our workforce, and domain 3 looking at inclusive leadership. We have to self-assess. We have to complete a self-assessment. We're scored. I've highlighted in the paper the scoring attributed to each of the questions under each of the domains. What I would like to say is that although it is a self-assessment, particularly for Domain 3, it is a requirement that we have to have independent testing by a third party. And we did buddy with Cambridge and Peterborough Foundation Trust in order to do that. So they have scrutinised our evidence base in answering the Domain 3 questions.
Okay.
And have confirmed that they agree with the scoring. Whilst it's only a requirement for Domain 2, we also asked them to look at our Domain 3 evidence base, and they have done that, and they've advised us on that. And again, agreed with our scoring. So out of a maximum score for Domain 2 and 3 combined is 21, we've scored 15. And you can see in Appendix 1 that highlights how we've arrived at that scoring. Domain 2 focusing on our offers to our staff and benchmarking actually from Model Hospital, Model Health now. And Domain 3 really focusing in on our board commitment in this space. And what I would like to say in that is we've really made some progress in there. Our exec directors have had EDI objectives now for some time, and our non-exec directors and chair I've met with individually around really devising objectives that build on the skills and experience of our board and the passions, but also in addressing the inequalities that we see are evidence in our organisation. And I say that because you couldn't just lift them and another organisation take them. It's really, these objectives are really tailored to our organisation. We've also made inroads in terms of governance and embedding EDI into our governance. Hence, we've got our BAF Risk 4, which can be reviewed by any committee and not just the People Committee. And then in terms of one of the questions in Domain 3, it talks about board members and senior leaders ensuring levers are in place for performance management and monitoring progress. And hence the paper talks about the newly devised EDI dashboard. And we're really devolving that leadership at a divisional level. So that will now go into those oversight groups at a divisional level and directorate level to be really driven at that level as well as at an organisational level. So I would just finish by saying that we haven't been able to do an EDS organisational rating and submit that as part of the template submission due to Domain 1 not having 3 services, and I'll let our Chief Medical Officer touch on that. And also just my recommendation to board would be, as I said, around the annual quality report, that EDS gets reported at the same time as our race equality, our workforce race equality standard, yes, our disability, and we bring it all together and do it as one, which is likely to be this autumn. So it's not going to be another year waiting to receive this report, and therefore talking about quite out of date data.
Okay, thanks, Amy. Girish, are you coming in at this point?
Yeah, thank you, Amy. Thank you, Di. I'm Dr. Girish Kunigiri, the Chief Medical Officer. I think Amy has kindly provided the background to this, and this part of the paper is to discuss about the progress on Domain 1, which is related to the patients we serve. And this is to again seek approval for the data which is attached in the appendix to be published. So with regard to Domain 1, it's expected that all the organizations will choose at least 3 services. One of them is performing well, one of them is not performing so well, and the third one where its performance is unknown. So the 3 services, as you can see in the paper, is the home treatment team from older adult division, and then is the eating disorder service for the adults from the specialist services, and from the inpatient services we chose the mental health urgent and treatment center, which is called MUAC. As you can see in the report, that unfortunately we have not been able to collect the data what is required for the mental health urgent treatment center because of operational pressures, and I have liaised with our chief operating officer in progressing with this once the operational pressures are relatively eased, which will then help us to do our rating if needed. So in terms of the key highlights of the paper, so two bits. One is with regard to the home treatment team. As you can see, they have really performed well in all the areas which are measured in terms of access, patient experience, patient outcome, and also incidents related to harm. There are no stark differences based on the protective characteristics, what we were able to collect based on age, gender, ethnicity, and so on. However, there was again a challenge which I had alluded before with the PCRF paper in terms of some of the data missing, particularly with regard to gender identity. The home treatment team has also been innovative in terms of collecting patient feedback and have worked very closely with the voluntary and faith sector in the community, particularly in terms of promoting the care for patients in the elderly. With regard to the adult eating disorders, some of the key highlights, you can again see that the percentage of referrals to this service is nearly half compared to that of the national figures, which means that we need to do more work in terms of promoting the service and people being aware of this. And what is also interesting that nearly 1/4 of the referrals to this service are from Lincoln. Again, this can be attributed because of the Lincoln University, which is in Lincoln. Hence, we have done a targeted approach, and we have started some specific pilots with the University of Lincolnshire related to identifying and managing people with adult eating disorders. We have also seen that the number of females who are treated is relatively more, which is again in line with the national data, and our outcome measures are again in line with the national figures. Again, one of the challenge what we noticed in this service is also related to collecting the protective characteristics of the patients who are referred. There are some robust actions in place which hopefully will improve this data for us. The other thing which was also noticed during our process is in terms of physical health monitoring for patients with adult eating disorder. This has been an ongoing challenge because of lack of specific commission services. However, having said that, we have now started a pilot project developing an integrated pathway with 3 of the GP surgeries. So it has been going on for 6 to 8 months now. There are clear action, to improve both the collection of the information and the feedback, as well as the outcome measures from the patients. So in summary, more work needs to be done to improve the data collection and meaningful interpretation. And I'm hoping that now that we have a health inequality lead, there will be some momentum continuing with regard to this. And I'm also hoping that once the operational pressures are relatively under control, we will be able to collect the data for the MUOC services as well. As a part of our plan, we want to make sure that in the next few months, the focus should be more on how we gear our staff in terms of meeting the individual needs of the patients, which also includes the patient's protective characteristics and the socio-demographic factors. So in summary, the request to the board is to approve for submission in spite of we having the data only for 2 services instead of 3. Thank you, and happy to take any questions.
Thanks, Girish. Can I just ask a really obvious question, which is, have we scored an own goal here by choosing the Mental Health Urgent Assessment Centre?
This was done many months ago because one of the criteria for in terms of choosing the services is one which has not chosen properly. and where there are challenges with regard to the performance issues. So that was one of the reasons why the MUAC was chosen. Yes.
Yeah, I can see why we chose it. I suppose what I'm trying to understand is, you know, did we know at the time that the data was going to be a real issue for us? You know, and if so, then could we have chosen somewhere else where maybe it would have been similarly unknown, but we knew that we had the data? I suppose that's what I'm trying to understand. It looks like there's a couple of comments in the colleagues that want to come in, and I don't know whether it's about this point or another point. So
yeah,
so that was just my question.
No, thank you for that. I know Chief Operating Officer may have something to add to this, but my understanding at that time was that yes, we do know about that, but we would be able to get some data for this.
Yeah,
thank you.
Okay. Yeah, Eve, do you want to come in? Because I think this is on this point, isn't it? Please.
Thanks, Di. Eve Baird, Chief Operating Officer. Yeah, I think there's been some real learning for us in ops around this year in terms of the level of resource that's required within the team to do the data pull and then analyse it to respond to the questions that we're asked. So I think that will inform which teams we select in the future moving forward, and not necessarily in us avoiding teams where there's operational pressure, but how can we move resource to make sure that we can complete this as well as continue with the pressures that sit in the delivery of the services. So I think that there's been some real learning for us about allocating specific resource to this piece of work, which we will absolutely do. We've got mitigations in place around some of the operational pressures, and we have made a commitment that we will review the data and provide the responses that we need to provide. We've just not been able to do it within this time frame.
That's really helpful, Eve. Thank you for that insight. Okay, Sarah, I think you had a comment.
Yeah, thank you, Sarah Connery, Chief Executive, and it was just to make a broader point really about what we're trying to achieve through this process, and this is something that I spoke to Girish about already, that the report feels very transactional about completing the EDS Domain 1 rather than what our strategy is telling us, which is we want to make sure that our services from access, experience and outcomes is positive for people who have protected characteristics. And that's not what I feel in this report. It's almost until we've got the data being input properly around protected characteristic, and then we've got the measures to be able to measure access, experience and outcomes along the lines of protected characteristics, we're just going to be filling in a report for report's sake. So I think we need a whole reset around this, if I'm being completely honest, but that was my comment. And I know Girish agrees, so thank you.
Yeah. Thank you, Sarah. I think that's really helpful. I think then in the meantime, we've just got to do what we're required to do, haven't we, and accept that we are where we are, but we've learned and we'll move on. Okay, so this is here for decision. It's been to People Committee. It's had plenty of scrutiny. So can colleagues just indicate that they're happy for this to go forward, please, in terms of making the information available on the website, etc. Right, that's fine. For Girish and Amy, you have approval for that. So thank you.
Thank you.
And then the final item in this section, Sharon, is with you on the wider learning from the Lucy Letby trial. This is for information, please.
Thank you, Di. Sharon Harvey, Chief Nursing Officer. So colleagues might remember that at the board meeting in November, the Trust approved the response to NHS England following its request around the Lucy Letby response, but we decided as a board, and the board requested there to be an initial further review from People Committee in relation to the wider focuses, wider than just freedom to speak up alone. So this report aims to demonstrate that and also to enable any further conversation, comments, discussion from the board. So the report hopefully outlines the discussion that we've had at People Committee, and if any colleagues want to come in on it, any bits at the end, really happy to do that. People Committee were assured with regards to our policy, process and governance in place. We did have a much wider conversation around culture and leadership, as Tim's mentioned earlier. and the conditions in which we enable our staff to safely speak up, and how we act, how we learn, but also how we triangulate the information that we receive. We talked as a people committee, and the paper outlines some examples of this. For example, the trends in freedom to speak up data that are analysed and presented to people committee that can then be more triangulated with HR and general people data. And our Freedom to Speak Up Guardian also meets with our head of safeguarding, the staff wellbeing team and the organisational development teams to try and triangulate information from there. We're trying to strengthen the voice of people and their families who use our services and people with a lived experience through both the Every Voice Guardian pilot and through the Council of Lived and Learned Experience to reduce the gap between the board and care delivery. But we recognise, in addition to that, that there is more to do. There's more opportunities to hear from staff through, for example, our professional councils, through the induction processes, but at other points as well. And the committee felt it would be beneficial for the board to have increased oversight of some of the detail in relation to the patient safety incidents and how we triangulate the learning from any incidents that we have through the newly established Continuous Quality Improvement Triangulation of Learning Group. So a report will be reported into the Performance Assurance Committee that can provide a twice a year report into board around what we've done in terms of the learning and how we've adopted that. I don't want to reiterate all the bits in the paper, so I won't go on much further in that. But I guess that the key point to make is we really did debate how can we really do better? How can we know? How can it not just be a tick box on a policy, but that we actually really hear from people who are working in our services, people who use our services and their loved ones. Happy to take any comments, questions, or if there's anything that other colleagues that have been part of the paper or the discussion feel I've missed from it, 'cause it's quite a tricky one to outline. Thank you.
Thanks, Sharon. And I think certainly the discussions that I've been party to in relation to this, I think, you know, our endeavours to go beyond the brief in terms of having a real good look was really taken seriously. I guess the only other thing to say is obviously the context around Letby goes on, and now there's been some questioning about the safeness of the decision. So obviously we can expect, I think, you know, this is not going to, it's not going to stop, is it? And I suppose it is that opportunity for the continuous learning going forward, really. Yeah. Okay. Any comments or questions? Thank you, Sharon. Thank you. Okay, now we're into best use of resources now. So Chris Wright, highlights an exception report from a best use of resources committee, please.
Thank you, Di. Chris Wright, Non-Executive Director, Chair of Best Use of Resources Committee. I had breakfast over listening to Amanda Pritchard, CEO of NHS, on being interviewed on the Today programme, talking about productivity in the NHS, which is a really good framing for the work of the Best Use of Resources Committee. We have been tasked with trying to focus on the sustainability of LPFT over the coming period, and there's going to be a relentless focus on our costs, the apportionment of our costs, cost of delivery, and how we ensure that the trust can operate sustainably going forward. I think it's fair to say the wider Lincolnshire health system has significant financial challenges, and as a consequence there'll be pressure on us going forward. And indeed in year, and some of that pressure is reflected in the annual pay award not being fully covered by NHS England, and so we've had to consume that within our own financial envelope. So over the next period we'll be focusing, as I said, relentlessly on how we manage our cost base and ensure that we're as well positioned as possible to meet the needs of the communities that we serve. So that was the kind of headline of the committee. In addition to that, we received progress report on the Best Use of Resources Committee Strategic Delivery Plan, and we're comfortable with the progress that's being made. In addition, we received assurance around our estate's compliance with the various regulatory requirements. There's been some concern that we've not been as on target in relation to that as we should been, and so we've been seeking regular progress reports on that, and we'll be receiving updates on a quarterly basis. And then finally, we received in relation to the Emergency Preparedness Resilience Response core standards, we've received partial assurance from the regulator in relation to that, but we're confident that the trust is well placed to manage any future emergency if one was to occur. So that's it from me. Di.
Thanks, Chris. Any questions or comments for Chris? No, that's very clear. Thanks, Chris. So the next item is with me, highlighting exception report from the Performance Committee. I'm going to take the paper as read. I think it was very self-explanatory in terms of what we talked about and how that fits into the wider trust strategy. So that's all really I propose to say about it, unless anybody wants to ask me any questions or make any comments. No, so let's move on then to the integrated performance report, which was considered at the Performance Committee, but is coming here as is required to board. So Eve, over to you for anything that you want to highlight from the IPR.
Thank you, Di. Eve Baird, Chief Operating Officer. As you've mentioned, the Integrated Performance Report has been thoroughly scrutinised at Performance Committee on the 30th of January. The report has month 8 data, so data from November 2024. Key items to highlight for the board, I think. Some positives around recruitment that we've seen on some of our wards that have historically been very difficult to recruit to, both the Vales at Discovery House and Langworth ward, our dementia ward. That's really positive for both consistency of support we're able to provide our patients, but also we should be able to decrease bank and agency usage on both wards as those individuals come into post. Also wanted to highlight the Lincolnshire Secure Unit received their Ofsted report in December last year, following CQC and Ofsted's visit in November 2024. The overall rating was outstanding, with children's health rated good compared to previous inspection rating of requires improvement in December 2023. So that was huge progress. The report acknowledged the improvements made, particularly in relation to medications management. Massive testament to the hard work of commitment of the team since the last inspection, and really good evidence of partnership working across the local authority and us as a trust. One of the main challenges we've seen over the last few months and is highlighted in the Integrated Performance Report has been high sickness levels. There's been focused support provided for the teams and services across the trust who have particularly been impacted by that, particularly where we've had high sickness levels in areas that have already got vacancies as well. It's really positive to be able to report that data that's been made available since the IPR, so month 10 data, does show that sickness rates across the trust have reduced a whole percentage since October 2024 when it peaked. So that's really, really positive, though still challenging in some particular areas. I wanted to highlight that we're not currently meeting the national target for young people who are referred to as with an eating disorder. You'll see from the Integrated Performance Report that the numbers are very, very small, which impacts the ability to achieve the percentage. What I am able to offer the board assurance on is that all of those individuals were offered appointments within the timeframes that the targets refer to. However, because of requests from the children and young people or their families around the convenience of those appointments and moving them. The appointments didn't happen within the target time frame, and unfortunately they're therefore recorded as not meeting the target. But we do review each and every one of those breaches to make sure that we have offered services within the time frame. The last two things I want to note are particular challenges. One in relation to trust finances that Chris has already referenced in his presentation of best use of resources. The year-to-date deficit position has required actions to mitigate this position during the remainder of the financial year and beyond. And function leads within the trust are working together to maximise financial sustainability of the trust moving forward. And the last challenge I wanted to highlight was, it's referenced in the integrated performance report, some of the challenges we're facing on the Vales ward at the moment, and their impact on patient care, experience of care, and staff's experience, as well as on performance, are also referenced. We've taken multiple actions to already respond to this. However, we have also, the Chief Nursing Officer has also convened a system quality review meeting to ensure that all risks and mitigations are understood both within the organisation and with our partner agencies, and that we've got shared decision making about further actions required. And that's it from me. Thanks, Dan.
Okay, thanks, Eve. Any questions or comments for Eve? Okay, we need to approve this, I think, Eve. So if people are just happy to indicate their decision. Yep, thank you. Okay, thank you, Eve. And then the final item in this section sits with me again, which is the Lincolnshire NHS Charity Annual Report. This is retrospective for 23-24. Just a couple of things to say about this before I open it up if anybody wants to ask anything. So the report reflects the new branding for the charity, which is the trustee of which is Lincolnshire Community Health Services, but the charity is run in partnership with ourselves in terms of the benefits to our staff and service users, as well as those to Lincolnshire Community Health Services as part of the wider group now. Those eagle-eyed amongst you will have, if you've done any analysis of the financials within this report, what you will have concluded is that on the face of it, we have distributed more money, but if you factor in the additional costs of the administrative support to do that distribution, we've more or less flatlined or even not spent as much as just slightly less than what we spent the previous year. So I think there remains a challenge for the charity in terms of getting the funds out to where they to where they can make a real difference. That notwithstanding, I think the report highlights some really valuable pieces of work that have really impacted beyond the level of finances in terms of staff wellbeing and satisfaction. So I don't think it's just about the money, but obviously the finances are important. And I think we are continuously looking at how we can maximise the way in which funds are distributed and the impact that they can have. But I think we need to be a little bit braver about that in the future and maybe think outside the box. So I'm going to stop there, but if anybody wants to ask anything or make any comments, then I'm happy to take them. Chris, I know we've had a conversation about this. I don't know whether you want to raise this in public.
Thanks, Di. Chris Wright, Ned. I probably don't know enough, but it just feels to me that it's not a particularly economic model, and I wonder whether the objectives of the charity could be aligned with the objectives of an existing organisation within Lincolnshire, so that you'd get better bang for your buck.
Yeah, and I think those are the conversations that we continue to have, really, particularly in light of shifts within the wider system with the group model in terms of where the charity might go in future. But the report is retrospective and it's here for information. So, okay. Thank you. So I think we move now into a section on regulatory issues. So Ian, are you still with us from the from the Costadel France for the highlights and exceptions report from audit and risk.
Yeah, I've heard every word so far, so thanks for that. So yeah, Ian Orrell, the audit chair. I'll take the report as read, and given the time, I'll be fairly rapid. Just 2 or 3 things to say, really. One of which I think has been pretty much covered off anyway. Just the earlier discussion on the BAF and the organisational risk register, where clearly good progress is being made, and the audit committee will continue to see that progress does continue, and in order to provide appropriate levels of assurance to the board. The other couple of points I wanted to make, one was one that the board will have heard me talk about before, that's internal audit. And I was a bit disappointed at the most recent meeting in terms of the progress on this year's audit plan. To put it bluntly, it's not going as quickly as we would want. And I think it's disappointing because we're not getting the value out of the work of internal audit, and it's a key. It absolutely links to the earlier point I was making about the BAF and the organisational risk register. It's clearly a key third line of assurance. So I'll be seeking to ensure that we sort of move that position on as we've done in the past, and I'm sure we can do so again in future. The other point I just wanted to make as well, one that I think is important and I didn't want it to be lost, is a lot of work has been done in the area of policies and procedures, where we've, I think it's fair to say, made a step change in the way we're organised and developing the policies and procedures, and keeping a close eye on their quality. So I was really pleased to see that, and again, it's a piece of work that the audit committee will continue to show interest in as we move forward, given it's a key part of our assurance arrangements. So that was as much as I wanted to say. Obviously, I'd take any questions that anyone may have.
Okay, thanks, Ian. That's really helpful. And appreciate you joining us while you're on leave, technically. Any questions or comments from anyone? No. Thanks, Ian. Thank you. Sarah, the next one is with you for the and this is for decision review of the executive team terms of reference.
Yeah, thank you, Chair. Sarah Connery, Chief Executive. So we'll assume the paper is read. So we've done our annual review of the terms of reference for the executive team, taking into account other changes through our governance structure. So happy to take any comments or questions, but it's here for approval.
Thank you. People happy to indicate their approval? Yeah. Thanks, Sarah.
Great, thank you very much.
Karen, I think we're with you now for the next few items. So the first one is the review of the forward agenda for the forthcoming year.
Yeah, thank you, Di. Karen Scott, Trust Secretary. So this is the board's forward planner for the remainder of 2025. It's just really here as a reminder, and just to identify, or for board members to identify if they feel there's anything omitted from that. Obviously, it can be as iterative as we need it to be, and invariably is where we need to add anything during the year, but just there as a reminder more than anything, Di. But we are asking for decision given that the current content is as stated.
Okay, people indicate their agreement, please. Yep. Okay, Karen, that's fine. So then the review of the trust constitution.
Yeah, thank you, Di. So this paper has previously been presented to the Council of Governors, given that any proposed changes to the Trust Constitution require both the Council of Governors and Board of Directors approval. So it's here today for the board to consider. I hope it's relatively straightforwardly set out, and it lists all of those suggested additions, amendments or queries that were raised by a number of governors, with a response and a rationale in each case for either declining the suggestion due to either legislative reasons or regulatory. So I won't go into any further detail and just ask the board if it's satisfied to approve the contents within the paper. Thank you.
Thanks, Karen. I think that was clear. Yes, I think we're all with you on that one. So then we've got the forthcoming board programme, which is slightly different to the review of the forward agenda, isn't it?
So this is really just a diary reminder for board members of forthcoming meetings over the next quarter, and I don't have anything to draw out of that. Again, we always respond with any changes as we need to.
Lovely, thanks, Karen. And then finally, the board assurance and escalation framework policy. And from the updates, this seems to be a sort of administrative housekeeping task that we needed to do, but it is here for decision.
It's one document, but given that it is the board's assurance and escalation framework policy, it has been through audit and risk committee and recommended for the board's approval, but it's one of few policies that will come across the board's table for consideration. So yes, here are set out. Di, thank you.
Okay, please can you indicate your agreement, folks? Got that? That's fine, Karen, that's all done. So I've not been notified of any other business unless anybody wants to tell me now that they need to raise anything. No, I'm not seeing anything. So I think that concludes the business of this meeting. I think we did have a lot to talk about. I think we've focused our attention where it needed to be on some areas where we had got some decisions to make, but I think I think it was helped because it was really clear the scrutiny that some of the papers had been through before they got to here, which is all part of that assurance process. So I think what we're suggesting now is that we have a brief break till 11:45, and then we will resume for the first section of the private board. So you've got approximately just short of 15 minutes, folks. Thanks, everybody. See you later.
Thank you.
Thank you.
Thank you. Bye.